Good morning, everyone. Welcome to the Buncke Clinic series of virtual visiting professor talks. On behalf of my partners, Drs. Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin, I'd like to welcome you all to this morning's lecture, or this evening for some of our other colleagues around the world. This morning we have the distinct pleasure and honor of welcoming a very dear friend of ours here at the Buncke Clinic and a member of the Buncke family, Dr. David Chang. From the University of Chicago. Dr. Chang really needs no introduction, but I'll take a couple of minutes just to fill you guys in on his background and where he is now. He is currently the Chief of Plastic and Reconstructive Surgery and Professor of Surgery at the University of Chicago. He also serves as the Director of the Microsurgery Fellowship in Chicago. Dr. Chang trained with Harry Buncke, and he did the Buncke Fellowship in the early 90s, 1993 to 1994. At that time, he also worked with Greg Buncke because Dr. Greg Buncke was also part of the clinic back then. His career has been very illustrious since. I'm going to ask folks to please mute your microphones. Great. If you're not speaking, please mute your microphone. Thank you. Dr. Chang has had a very illustrious career, and over the past 20 years has accomplished quite a bit, first at MD Anderson and subsequently at the University of Chicago, where he's currently now chair. In 2018, he was the 2018 ASRM president, and in 2019, this past year at the meeting, he was the ASRM Buncke lecturer, and he delivered his lecture in Fort Lauderdale this past January. He's a member of the Harry J. Buncke Society. He was a visiting professor for us in person last year, and he's a world-renowned expert in many fields, including lymphatic reconstruction, head and neck surgery, as well as breast reconstruction. As I mentioned, Dr. Chang was the Buncke lecturer last year, and this is Dr. Greg Buncke and I after his fantastic lecture. I unfortunately missed Dr. Chang when he was visiting us last year as visiting professor. I was traveling as part of my travels, but I did have the distinct pleasure of visiting him and his colleagues, including Dr. Larry Gottlieb and all the other faculty and residents at the University of Chicago. And this was a phenomenal trip and really kind of par for the course as far as Korean hospitality goes. Dr. Chang hosted a fantastic dinner at a Korean barbecue place, and he's just always been the consummate host and the most welcoming person. I also had the privilege of serving on council during his presidency year, and this is our council meeting in Chicago. And so it's been really kind of fantastic getting to know him and being mentored by him. During that trip, I had another chance to visit the University of Chicago as well, as you can see here in this picture. So with that, Dr. Chang, thank you so much for being with us. It's an honor and a pleasure to have you, and we're really looking forward to your talk. And for the viewers, this is Dr. Chang's first talk, and he has actually agreed graciously to give a second talk to us in a few weeks. The schedule has been posted, so you should be able to see that. And today he'll be discussing his work on lymphatic surgery. David, I just made you the presenter. So okay. If you press the button to, oh, there you go, perfect.
Yeah, and then do I just...
Anything you show on your desktop?
It will show up there.
Yeah.
Do you see that?
Yes, we can see that.
Okay, good. Thank you.
And then if there's a GoToMeeting window hovering on top, you can minimize that by pressing the two arrows, and it'll just shrink it to a...
Yeah, yeah, it's gone now. So do you see my slides?
Yes, okay, and we can see your pointer as well. So if you want to use it.
Fantastic.
Great.
Thank you so much. So my topic today will be 2020 update on surgical treatment of lymphedema. I think many of you may have heard my talks on different variations of this, and I also gave a variation of this last year when I visited Buncke Clinic. But I have some new updated information here that I want to share with you. And I know there were a number of other speakers who have given talks on the lymphatic surgery, so some of this might be redundant. So I'm not going to go too much into the introduction, as many of you are already very familiar with it. So this is University of Chicago here, and this is the main hospital that where I do most of our surgery. This is our surgical unit here on the 7th floor. Clinics are located over here, and our labs and the medical school are here, and then the rest of the universities just adjacent to it, just south of Chicago, downtown, and Lake Michigan. And we have been affected by COVID-19 like everyone else, but we are starting to open up. In terms of the hospital capacity, I just recently looked at our number. Our clinic volume is actually at 100%. Our OR capacity is, I think we're over 80% now, and I think by next month we will be close to 100%. So we are ramping up pretty quickly. Yes, one of the most memorable time in my training was the 1 year I spent in the Castro Avenue in San Francisco at Davis Medical Center with Dr. Buncke, Greg, and the others. And one of the hand therapists always used to take this photo of a fellows and then give this as a graduating gift. And it hangs on the wall of my office. It was, for me, a really awakening moment, really helped me to become a microsurgeon that I am today. I had a pleasure of going back there when I was Goodenough Fellow in 2005, and here is Harry in his office. And then last year, as Bob mentioned, in March, I visited and here with Greg in the lobby of the Davis Medical Center. And again, it was a great honor for me to have been selected as a Harry Buncke lecturer at the ASRM this year. Today, I wanted to give you, this is kind of the agenda for the talk today. Interesting thing is that the first lymphovenous bypass I've ever done was when I was a fellow at the Buncke Clinic. I remember the case, not a lot of it, but one thing I do remember was it was very difficult. It was a leg. We injected methylene blue between the web spaces, and we were looking for lymphatics. We're trying to find it in the leg, and it was not easy. It was very difficult. I don't know how much the patient got better or not. I don't remember, but I just remember it being very, very challenging. And a lot has changed since. Why isn't it advancing? There we go. My disclosure, lymphedema surgery, first edition. Second edition should be coming out shortly. So you already know about lymphedema, but it's when there's a failure to lymphatic system. And this is one of the more severe cases. And there are primary lymphedema that the patients can have due to developmental abnormality. And secondary lymphedema, which is the kind of lymphedema that I most likely see, most of us will see, either due to the surgery or to the radiation or parasites. So in the United States, we don't really see this. In fact, I have never seen filariasis, even in those patients who have traveled elsewhere or who have come from elsewhere. Sometimes I do have some patients from elsewhere, but I have never seen filariasis induced lymphedema, but this is very, very common. And I see that many of the visitors from India, I think this is very common in that region of the world. In the United States, the most common type of lymphedema, so I'm trying to get my mouse to work, it's not working. Here we go, is secondary, mainly due to breast cancer, right? Because of axial lymph node dissection. And we expect anywhere from 5 to 10 million. This is the United States alone. So it's very common. And we expect that the incidence to increase. And I think it is, because the various different factors that are associated with lymphedema are increasing as well. Obesity, particularly in Western culture, obesity is a major problem, more radiation use, and people live a lot longer now. So during their lifetime, the chance of getting lymphedema is higher. It is a lifelong problem. It doesn't get better. It's very debilitating. Again, this is one of the more severe type of lymphedema. As you already know, lymphatic system kind of mirrors our vascular system. There are lymphatic capillaries, and there are lymphatic vessels in the subcutaneous layer, just under the dermis. There are lymphatics that are deep within our muscle that travel with our main blood vessels, and they all eventually drain to the venous system, both on the thoracic duct on the left side, and the lymphatic duct on the right side, about 25% to the right side, 75% to the left side. And until I started doing lymphatic surgery, I was not aware that the lymphatic system was an active system. I always thought that this thing keeps popping up. I always thought that the lymphatic system was a static system, but it's a dynamic system with the smooth muscles within it that contract. And when there's a lymphedema, the fluid that's been collected causes the inflammatory process, fat deposition, tissue fibrosis, and then further lymphatic increase in lymphatic pressure, and it's a vicious cycle. So the surgery that we're doing is trying to break this cycle at some point, to break this cycle. And now we know that it is not just a fluid. We have always, in the past, kind of concentrated on this fluid component, but we know there's a fat component and there's a tissue fibrous component. And for the most part, the physiologic procedure that we perform, lymphovenous bypass and lymph node transplant, actually focus mainly on the fluid component. That's why it is very rare for us to get 100% cure in these patients. If they already have a fat deposition that make up a significant part of their problem, that is not really gonna be reversed immediately with the lymphovenous bypass and lymph node transplant. And this is something that I always discuss with our patients so they're aware. And here is a slide showing how the lymphatic fluid causes adipocyte proliferation. And this is a slide that many of you may have seen that Hakan Brolson had shown, where in a patient with a lymphedema leg, not a patient, a cadaver, with a cross section of the leg showing how much fat that's been deposited due to a lymphedema. And here MRI demonstrating early on the fluid has been replaced with a lot of fat deposition. And I think the biggest problem with lymphedema is that it actually causes damage to itself, to the lymphatic system. It causes damage to the pumping abnormality of the lymphatic system, damages the smooth muscle cells. It causes the lymphatic fibrosis and the leak. And that's a problem. And when we go in and see this patient with lymphedema and looking for lymphatics to bypass, many of the lymphatics are already damaged and there's no fluid in it. It's been obstructed, it doesn't pump, so it makes the surgery ineffective. And here's a nice cross section of normal lymphatic vessel demonstrating the 3 layers, just like a blood vessels, with the intima, media, and adventitial layer with the smooth muscle cells within it. And then here's a cross section of lymphatic vessels, again showing a significant destruction of all 3 layers, and in some cases even obstruction of the wall. So when I have seen all these different phases of lymphatics when I do surgery under the microscope. We find lymphatics. Some of these, when you cut it, there's nothing in it, and the smooth muscles probably don't work. So when you bypass these, chances are they're not going to be they're not going to be effective at all. I'm going to just quickly go through medical treatment. There are many options available. Some of them are controversial, but it is an important part of a patient's lymphedema surgical treatment, because at least in my hand, most of the patients are not curable. So even if we can make them better, they still have to live with some sort of lymphedema, whether it's mild. And it is important they have a regimen that works best for them. And I individualize. I don't have a protocol for anybody because everybody's different. So they have to work with the therapist and use the types of techniques that works best for them. Sometimes compression garments don't work for some patients, and pumps don't work. Definitely have to lose weight, get into some sort of exercise program. Those are, I think, very, very important. So these are the 2 procedures that I currently perform: lymphovenous bypass and lymph node transplant. So I'll talk a little bit about my personal experience and my personal journey and how I have changed over the past, I say it's been 15 years now. So lymphovenous bypass, you have a lymphatic system that is occluded. So you create a diversion or detour so that the obstructed fluid can escape into open system. Simple concept. Julius Jacobson, who also first coined the term microsurgery, was the one who first reported end-to-end anastomosis in the dog model on lymphovenous bypass. And then a Polish group led by Dr. Orjuski did the lymph node to the vein bypass. I think they published this in this paper. They had 5 cases. And I know they're still very active in doing lymphatic research and surgery in Poland. And then Bernie O'Brien in 70s and 80s published in PRS his experience with the lymphovenous bypass, but he never really gained popularity globally. Until with the advances, I think the idea of lymphatic surgery was perhaps more advanced than what could be done at the time. It was perhaps an idea that was ahead of its time. With the advances in microsurgery, with the better equipment, with the super microsurgery, we found a different way to do a lymphovenous bypass procedure, for example, with the connecting subdermal lymphatic into the subdermal venules. And in this area, if you have done surgery of this type, you'll notice that some of the veins really have no backflow or very low flow, making it suitable to do a bypass so that the lymphatic fluid from high pressure system can drain into the low pressure system. And I just happened to be visiting University of Tokyo in 2005, not knowing that that I'd be interested in lymphatic surgery. I happened to see him do lymphovenous bypass for the first time. I've never seen anyone do it this way, and I thought this was something that I felt my patients would benefit from. So when I got back, at the time I was working at MD Anderson Cancer Center, and most of my cases are cancer patients, particularly breast cancer patients. So I recruited patients with a breast cancer patient with lymphedema and started doing a lymphovenous bypass procedure. And here's a video of one of my earlier technique. Here is a vein, branch of a vein, and there's a lymphatic. This is about 1 millimeter, so it's about 0.3, 0.4 millimeter. Using essentially standard micro instruments and standard micro sutures at the time. That's all we had. But this is one of the better ones because sometimes you cannot find anything. And then you just bypass it and hoping for the best. And we happen to have barometer, which is actually a very good way to measure the volume of the lymph. This is made in Germany. It's not available everywhere. Even in the United States, it's hard to get a hold of because there's no vendors here. But this was how I measured the patients before and after to just kind of track their result. And we found that after about a year, most patients had a significant improvement, ranging from 30 to 40% reduction in excess volume. And then this is one of the examples of earlier patient. After about a year, you can see there has about 40% reduction, about the average of most people. But we had a hard time finding these lymphatics that I could bypass. It was purely by like search and identifying it just randomly, making it, and so that was a very, very challenging. That was very time consuming. And then I was approached by this company in Japan who was trying to get into the United States market called Hamamatsu. They had this PDE machine that allows us to use indocyanine green to map out the lymphatics. And here is in a normal volunteer showing the lymphatic vessels. And in thin patients, you could actually see a dark shadow, which correlates with the vein. And this was something that I thought would be very helpful. So here's an example of how normal lymphatic would look. And then in lymphedema arms, you could see lymphatics here, and then there is no lymphatics here at all. But this is what we call dermal backflow. Essentially, it's lymphatic capillaries that are dilated. But what it did was it give us a map of the arm or the leg of where the lymphatic vessels that are traveling. So I could actually precisely identify and make incisions and do the bypasses. And this is a total game changer. It allowed us to easily identify functioning lymphatic vessels. So these are the lymphatic vessels that still has fluid in it, and then smooth muscles are still working. And I didn't have to like make incisions all over the arm or the leg looking for them. I knew exactly where to go. And then it also helped us to see the patency. After the bypass, I can see the dye go across the anesmos into the vein, so it confirms a patency. And here is just how it looks in a naked eye. And then here's some lymphatics. Here's a nice lymphatic, soft wall there. Here's a lymphatic that has fluid, but you can see the wall is somewhat corrugated. Here's a lymphatic with the isosulfan blue turning blue, which makes it very easy to identify. And then now the microscopes, you can flip into the fluorescent mode. You can see the lymphatics. They light up because of the indocyanine green within it. And then there have been a lot of advances in the technology in terms of microscope. Now we have a microscope that actually you can zoom in up to 40x and then still have a very clear, bright picture, so you could do the surgery. And then there are super fine instruments that are much finer than the standard micro instruments. And then there are super fine needles and sutures that are much smaller than the standard micro needle. That makes the surgery even easier to do. So here's a more recent, well, it's not that recent, this is probably about, I don't know, 6-7 years ago. But we are able to do the bypass here similarly, and you can see this lymphatic is pouring out the lymphatic fluid. Okay? It's just pouring out, and you will see the vein here. It's filled with lymphatic fluid spontaneously. And these are the type of bypasses that we are always trying to do, so that you could see the result immediately on the table. And we're going to do a little milk test here to squeeze the lymphatic fluid out of the vein, and you will see it's filled in with the lymphatic fluid immediately. And this is the type of bypass that I think can be very beneficial for the patient. So with the ICGN, you can see here's the endocyte. Now, if I don't find a good vein that I can connect to because of pressure, then I just do endocyte, and you can see the dye go into the vein. And same thing with the isosulfan blue, you can see that. So I think it's important to check the patency after the anastomosis to ensure that the bypasses you perform are going to be effective. And this is a more recent publication after 100 consecutive cases, essentially kind of confirming my earlier publication. Maybe a little better result, probably because we're getting a little bit better at it. We also staged the arm looking at the ICGN as a way to classify, and these are more milder forms and more severe forms. We found that, of course, the patients with more lymphatic vessels that are available with less fat deposition and less tissue fibrosis, patients do better with lymphovenous bypass. And same thing. Many people have been doing research in lymphedema area and have found that inflammation and fibrosis play a critical role, and they lead to elevation of various different factors. And one of the persons who have been doing a lot of lymphatic research, particularly with the rat tail model, was Buncke, who's now chair at the Sloan Kettering. But he wasn't doing any clinical case at that time. Now he is. But we collaborated. So I took the tissues from the upper arm in patients with unilateral lymphedema who was going lymphovenous bypass, and then using the other side as control. And we took tissue biopsies and measured these factors before surgery and about 6 months after lymphovenous bypass. We hope that our hypothesis was that if lymphovenous bypass is effective, then these factors that were elevated should go down after bypass. And then that's what we found. So the left side is the control group. As you can see, there's no difference. And this is lymphedema side. And this is prior to surgery, and this is after the surgery. All the factors went down significantly, kind of confirming what we found clinically. And it was good confirmatory information for us. Now, vascular lymph node transplant is something that I do a lot nowadays, but I was not, I don't know, I was very skeptical at the beginning. So I initially just did lymphovenous bypass. I was concerned that the lymph node transplant may cause harm to the donor site, and it can. And I wasn't sure of the mechanism. There was there's confusion as to how lymph node transplant actually works. Is it by lymphoangiogenesis or is it by pumping mechanism? And I think we're still actually arguing about that. But nevertheless, I think it's a very useful tool, and I use it a lot nowadays. And the first publication, again, was in an animal model. This was in a rat model as a pedicle lymph node transplant. And Chang, who's at who used to be at Chang, was a fellow with the Bernie O'Brien with Julian Privas, did the lymph node transplant here in a dog model with a microsurgery. And here are the two different types of mechanisms that have been described, lymphoangiogenesis and pumping mechanism. And I think they both work simultaneously, actually, depending on where you place it and depending on whether you use a skin pelt or not, because I have done it both ways and I found it to be effective both ways, putting it proximally or distally, depending on a patient. So this is from Corinne Becker, who's done a lot of earlier work in her publications, Annals of Surgery in 2006. Patient with the lymphedema of the left arm, lymphoscintigraphy before the surgery demonstrated no activity on the left side. And after lymph node transplant, and this is one's 1 year out and one is like 8 years out, you can see new activity that was not there before. And again, the concern about donor site morbidity, I think this is very important. And I think if you're going to do lymph node transplant, you have to pay attention to the anatomy. You have to know where sentinel nodes are. For example, from the groin, which used to be the most commonly used lymph node transplant, you really want to stay away from the medial area, because that's where the sentinel nodes for draining the legs are located. So we focus on taking lymph nodes more laterally. And this is a study that from Finland, they've done a lot of research over there, demonstrating in 13 patients where lymph nodes were taken, even though none of the patients had clinical lymphedema, when you measure the transport index with lymphoscintigraphy, essentially this is a speed at how the lymphatics are draining the leg. In many patients, the function was compromised, even though clinically they were not having lymphedema. So this was a very good paper. And then this is a paper from France, published by the rehab doctors. They reported that all these patients who had lymphedema surgery, lymph node transplant, now they're showing up at their clinic, all kinds of complications that were not being reported by the surgeons. So it is important to follow your patients for a long time and make sure that they're not having any complications. So these are the options of lymph node transplant that are commonly used these days. And I will share with you some of my experience with these. This was my first patient that I did lymph node transplant because when he came to see me, I didn't feel he was a candidate for lymphovenous bypass. His leg was hard as rock. I didn't think there'd be any functional lymphatics available. He wanted like amputation of the leg. And so I said, well, we could try lymph node transplant. I've never done it, but we could give it a shot. And, if it works, it'd be great. If it doesn't, then you don't have much to lose, perhaps. So we decided to do that. Because of his lymphedema was right leg, I didn't want to go to left groin and cause bilateral lymphedema. So I decided to go into the neck. So, having a lot of experience with head and neck reconstruction, I know there are a lot of lymph nodes here. Zone 5B based on transverse cervical artery in the vein. I thought it would be a good way to take lymph nodes. So, written by Artubati, who was a fellow at MD Anderson, but also a fellow at Buncke Clinic. So take the lymph nodes, and then that's how we did this first case. I took a skin pedal with it, with external jugular vein, injected a flap with the ICGN, and so the lymph nodes light up, transplant down to the ankle. And then 3 months later, without anything else, I did not do any kind of resection or anything like that. His leg got much smaller and softer, and he was a happy camper. But then I didn't see him after that. This is he never came back, so I don't know what happened to him. Now this technique has evolved quite a bit. I no longer take skin pedal. I've had several problems with skin pedals, and I say about 20 to 25% of the time I found the skin pedal to be not that reliable, so I just decided not to bother with it. And then my incision is much smaller. I can do it in about 3 centimeter incision between sternocleidomastoid and external jugular vein. And when done properly, I can probably get lymph nodes out in about 20 minutes, maybe 30 minutes at most. So incisions made just above the clavicle, about a centimeter or so, along the natural skin fold. And then you divide the platysma muscle, and then you find this sternocleidomastoid, you retract it, and then you find external jugular vein, and then you dissect between the external jugular vein. External jugular vein does not drain lymph nodes, so there's no point in taking it. So you dissect between this little small space, and then you'll find omohyoid muscle, and I divide it so you can get a better access. Some people just retract it away, but it keeps getting in the way. And then you find the internal jugular vein, and then you just hug the lateral wall and just dissect inferiorly. You're gonna see a bunch of lymphatic vessels there, maybe even a lymphatic duct or even thoracic duct on the left side. So you have to be very careful. You have to clip every little lymphatic so you don't get a chyle leak there. And then you will find a transverse cervical artery and the vein branch coming up in that area. Now, in patients who are obese, where it's hard to find, sometimes it's easier to just go push back here, where you find the transverse cervical artery and the vein that are going to the trapezius, and then work backwards. Sometimes that's just easier. And then you, once you find the pedicle, then you can lift up the lymph nodes that are buried within all this adipose tissue, and you will see the lymph nodes. They're like, you can see one right here. You will just grossly see them. And you dissect it off of scalene muscle. Of course, on top of scalene muscle runs a phrenic nerve, so you have to make sure you don't cut that. So there are a lot of stuff there that you have to be careful. You cannot just go through the cautery. You're going to cause all kinds of problems. And I know there have been some reported complications with this, with the even secondary lymphedema of the arm. But if you're not careful, you can cause a lot of problems. So here's some lymph nodes and the fat tissue isolated on the transverse cervical artery and the vena comitante. Now, the VCs can be very small, and you may not even be able to use coupler, for example. So you may have to hand sew those. And here is after the lymph node's been lifted, you can see the scalene muscle is a phrenic nerve that's been preserved. And after the lymph nodes are taken out, this is how the donor side should look. Very clean, no blood, no. If you see like liquids building up, that's a lymphatic leak. If you just avoid it, it's going to cause a problem. So you have to make sure everything is clipped or tied off very meticulously. I do put a small drain in there and then close over. Now, I have cut lymphatic duct or thoracic duct, not many times, maybe 2 times. And then if you recognize it, hopefully you will, you can bring a microscope and just repair it. Just to lymph bypass right into the vein. And then you just close the skin here. So here is just a little video, probably like 4 or 5 years ago, but really not hasn't changed that much. So here the sternocleidomastoid identified, retracted, omohyoid muscle identified, and cauterized. And once you go through the omohyoid, then it's a bipolar time. You don't want to cauterize that with the cautery. And now there's internal jugular vein. As you can see, I'm just dissecting down the lateral wall. And here we are carefully looking at any lymphatics. I think I see some lymph nodes right there. Just carefully looking at any lymphatics. And then with the Army Navy, just retract carefully. And we are looking for transverse cervical artery and the vein. And the anatomy is not all that consistent. Sometimes they come off very proximally. Sometimes they come up higher up on the more caudally. So it's not always in the same location. And sometimes the transverse artery can be, or the branch of it can be very small, and sometimes can be very large. If it is small, then I sometimes follow the branch down to the thyrocervical trunk, and then just take it off in that area where it's much larger. So now I've identified distal end here, and I'm just dissecting it off of the scalene muscle. You will see a lot of this is fat, and here is the distal end of the transverse cervical artery and the vein. You can actually use this side. If you have a hard time finding something there, you can just connect it here. And putting micro clamps on it, and then dividing it, and coming more proximally. So sometimes it's easier to just find distally and then go work retrograde. So this is left side of the neck. I prefer right neck in most patients, unless patients right on lymphedema, so that I avoid the thoracic duct. And the scars look very nice. Of course, these are Caucasian patients, but even in ethnic patients, scars usually heal very nicely in this area in the neck. And this was my 100 consecutive cases that just looking at the donor side complications, I monitor all my lymph nodes. So I bury them and I put implantable Doppler. And if the sound goes away, then I explore. Some people don't do that, but I do. We had 3 exploration. 2 of them are actually Doppler just fell off because vessels can be very small. There were 2 Kyleaks. This was the first 100. I've had more since then because I've now done like 300 of these. Some infection, and so far have not had any donor site lymphedema. Now, in many of the patients who come to see me for lymphedema also have absence of breast. They never had reconstruction, or they had reconstruction, but they're unhappy with it because they had an implant and got radiated. And there's opportunity to do combined breast recon lymph node transplant with the abdominal flap, deep flap muscle sparing with the lymph nodes based on the circumflex vessels. And then you can do the breast reconstruction and perform lymph node transplant at the same time. And this is something that a lot of patients are happy about. You kind of kill 2 birds with 1 stone. So here is that paper again, first published by a Finnish group, demonstrating after the combined procedure they can start to see activity in the arm of lymphoscintigraphy. So this is my patient, perhaps one of my earlier patients, long-standing lymphedema following mastectomy radiation, no reconstruction. So we did what I do is I inject technetium 99, and then I do reverse mapping, just like the breast surgeons do with this probe, and then stay away from the hot nodes. So if you don't go medially, you're not going to get into hot nodes. They're always very medial. So I find the circumflex vessel like you would do with the going flap, and then just dissect it off, all the lymph nodes together. And then you stop at the SIEA and SIEV. You don't want to go more medial to that. So here is a deep flap, single perforator with lymph nodes and circumflex vessels. And on the abdomen, you take the chest. I usually flip the deep inferior epigastric into the intramammary, and I do the anastomosis. I inset the flap so that the lymph nodes and the circumflex vessels are in the axilla. I shape the breast, and then after I complete it, I make a counter incision in the axilla, and then just to connect to the anastomosis in the axilla at the end. I find that much easier. If you connect both vessels, it becomes practically impossible to shape the breast because you're afraid that you're going to avulse something. So this is some of the earlier ways we used to do it. It's been changed. I usually take it on the same side now, because if you do it this way, the flap just becomes too big in most cases. But nevertheless, you can connect the lymph nodes to the axilla and then the D flap into the intramammary outer end. So this was in Annals of Social Oncology, 2013, 29 consecutive patients, similar to other types of lymph node transplants. So people say, well, do they work? If they work, which one's better? When should you do bypass? When should you do lymph node transplant? So this is a difficult question, right? I think there are some people who only do lymphovenous bypass. There's some people who only do lymph node transplant. But I think people start to realize that there's actually a role for both. The question is, when should you do one or the other? And the American Association of Plastic Surgeons, I don't know how they got these names, but they asked us to get together in Boston 2017. So we actually sat in a conference room and went over all the literatures and came up with the way to analyze the current data and come to the consensus. Actually, it was supposed to be presented this spring in association meeting, but of course it was canceled because of COVID. And it will be presented next year, and it will be published in PRS. But we use this GRACE system to see the evidence and the strength of the different approaches. And what we found is that we went through all these publications. This is actually really updated last year. There were like over 2,000 publications on lymphedema. But once you exclude them for various reasons, there were only 66 cases that were actually that met the criteria for meta-analysis. So a lot of cases are just like case reports or very anecdotal things. They don't have a control group and things like that, so making it very difficult to do any kind of scientific analysis on. There's something that we all need to work on. So we found that the lymphovenous bypass, based on the literature that's been published, show that it can be effective, particularly earlier stage, but there's no evidence that it cures lymphedema. So anyone who says that lymphatic surgery can cure lymphedema, I think we have to be very careful about sending the message to our patients, because I think many patients will be disappointed. And the lymph node transplant, same way. There is some, it can be effective in reducing severity, but it doesn't cure. There's no consensus which is better. So what we know is that lymph node transplant generally takes time to work. Now, if you put more distally, it does work a little bit faster. I have noted that. Now, lymphovenous bypass usually can be done more distally. I think because when there's damage to the axilla or the groin, the destruction of lymphatic vessels occur proximal to distal. So there are more distal lymphatic vessels that still have a functioning smooth muscles. And also the tissues are more superficial, so it's easier to do surgery there. But if it's effective, you will see the results right away, even next day. And it can be done minimally invasive. So they work very differently. So my thought was, since I came to Chicago, why not just do both at the same time? And mainly because also another reason was that a lot of the patients that I see are from out of town. So, if I can just do everything at one time, then they don't have to come back and do the other procedure in case one doesn't work. So I generally put lymph node transplant more proximally, particularly like in the arm, in the axilla or the scar, even for the leg, generally more proximally. And then while we are waiting for lymph node transplant to work, whether it's 1 year or 2 year, we do lymphovenous bypass so that they start to work right away while we're waiting for lymph node transplant to work. And I found that to be an effective way of doing it. So here's a patient, the melanoma induced lymphedema of the left arm, and you can see ICGN showing significant dermal backflow. So here's a lymph node transplant into the axilla, lymphovenous bypass. Here's an entry side. You can see the big vein here. I did 2 of them. You can see one here and one here. You can see the dyes going in there. This is 1 year later, about 37% reduction. So considering how severe the arm was, that's pretty good result. And this is another patient with the breast cancer induced lymphedema of the right arm, and you can see lymphatics here. So I was able to do 4 bypasses, and here after a year, about 56% reduction. So over the past 6 years or so, over 350 patients had this combined approach, and over 300 have more than 1 year follow-up. Some I have follow-up for 5-6 years now. And we've analyzed this. This was actually supposed to be presented at the association meeting. Of course, it was canceled. It'll present next year. It's been submitted at various journals right now for publication. And what we found is that secondary upper lymphedema, significant volume reduction. Even for lower lymphedema, there has been significant reduction, but not as much as the upper. Even primary lymphedema, I know a lot of people say, oh, you should not be on primary lymphedema. You know what? The results actually we've had have been pretty impressive. And I think I think a lot of patients with primary lymphedema have benefited from this. So I don't think you should just say, oh, you got primary lymphedema, you shouldn't have surgery. So that's something that we found to be a pleasant surprise. So secondary upper lymphedema, when we look at our group, 85% had a reduction in excess volume postoperatively, and this is numbers. And you can see that even at 4 years, almost 50%, so they continue to get better. I think this is when the lymph node transplant start to kick in around a year later, start to get better. And 85% had improvement in quality of life scores and improved the subjective improvement. So, we keep a prospective database on all the patients. We get the measurements and we get the LLIS scores. These are all the data from our own therapists. I don't use the data from their own personal therapists at back home because it kind of mixes up the data. And we did all the analysis with the multivariate analysis with the biostatistician who helped us with this. For the lower extremity, not as good, but still, over 60% had reduction in excess volume. And you can see that even here, as time goes on, they get better. And over 75% patients felt that their quality of life score was improved. So I found this to be very promising. And then primary lymphedema, when you compare that, primary lymphedema patients also had significant improvement, both in the volume and the quality of life score. But as time goes on, because the sample size is small, we really don't have any statistical or meaningful conclusion. But we will continue to follow these patients. So patient like this with a large fatty lymphedema, these patients are not very good. They're not ideal for physiologic procedure. So there's a role for liposuction. But one thing that you have to realize and allow the patient to know is that when you do a significant liposuction, they do have to wear a garment pretty much around the clock. So here is a liposuction done and a lot of excess skin. I know a lot of people are actually cutting these out, and this actually might not be a bad idea. But in this patient, I did not do that. But even without it, this is 1 year follow-up. There's significant improvement. It's not as good as a Hawk-Broson's result, but quite a bit of improvement. And so literature does support the liposuction as one of the ways of treating lymphedema. Patient like this, though, however, liposuction would not work. You couldn't even liposuction. These are all like rock hard tissues. So for people like this, debulking, there is a role. This is a bird's eye view with the extra table next to it. And you take the skin. If you have take the skin graft from the leg, from the sites that are actually nice and smooth, you save them. And then you debulk, you take it down to the fascia, and then take it out, and sometimes in multiple pieces if necessary. You skin graft, and here's some pieces. And it takes a big, strong guy to hold them. And more pieces here. Skin grafted. I sheet grafted if possible. I think they look better. Put a wound back on it if you have that. And then this is how it looks. I didn't take everything off. I took off these areas. And while this doesn't look that great, I think compared to left side, it's significantly better. So she was able to actually now wear normal clothing for the first time in over a decade. And now she's able to get out of the house and actually work and go shopping and go to restaurants and go hiking. And so her life is kind of, much improved. This was a very, very difficult case because tissues were so rock hard, like even that scalpel would break continuously. So here, after the skin graft, it's improved. I mean, it's not great looking, but it's much better. Even his foot was involved. All the toes were involved. Another case that we did not too long ago involved the lower extremity. So we got better at it. So it just takes a few minutes to peel it right off. Anyway, I've done probably well over 500 now. And the lymphovenous bypass, I do it in some patients with very mild lymphedema. They just want to do something minimal because there's an outpatient. If I'm doing breast reconstruction with abdominal flap, I usually just do that. And then I scan the arm with the ICGN. And if they're good candidates, when they come back for a touch-up, I can do a bypass at the time. Most of the cases, I will offer both procedures. And it's patient's decision, but most will say, sure, let's do both. And that's what I've been doing. And I do some liposuction occasionally, and these patients who come back with a few spots here and there, they need to kind of touch up. I will do like limited focus liposuction. It's rare for me to do the complete liposuction of the leg, like the case that I showed, but I have done some of those. And then I do some debulking case for extreme cases. One thing that we also been doing a lot is the Lympha. So this is something that's been popularized by the group from Genoa, Italy, and to help prevent the lymphedema in patients. So I did one yesterday. I have one today. After this talk, I have one today. We are collecting our data. We don't know whether it works or not, to be honest with you. I think some of these publications really are weak in that they don't have a control group. Their follow-up's very, very short. So we don't know. I mean, this one follow-up of 6 months, that's too short. And there's no control group. So right now, the literature is weak on whether Lympha works or not, but I know a lot of people are doing it. We have a protocol. So there are 3 of us who are doing this right now. So hopefully we will have some reasonable result. I think you have to follow them for like at least 2 years to see if it's helpful. Anyway, it's evolving. current solution is prevention and early intervention, I really believe. And we do have this World Breast and Lymphedema Symposium set up next spring. Hopefully everything will be back to normal and we can do it in person in our brand new facility here. But obviously everything's kind of up in the air now. But hopefully by April things will be fine. But we don't know for sure. Anyway, that's the end of my talk, and I'm happy to address any questions. Thank you very much.
Well, thank you so much, David, for a typical fantastic talk from you. It's been really fun kind of watching the progress of your work in lymphedema in general with regards to the data. I think initially we can all agree that lymphedema surgery, there wasn't really much data for it, or at least long-term data to know actually what works and what doesn't. And I think a lot of the work that you've done, including the consensus statements, I think is really good to see. I had a couple of questions of my own, and then some questions and comments from the audience as well that I will ask. So I've actually visited you and watched you do a supraclavicular node flap, and I've seen the results. So obviously they work quite well. I wanted to get your thoughts on some of the other flaps that have been described. We've had Dr. Mingwei Chang from Chang, who, as we know, is a fan of the submental lymph node flap. We've had Joe Diane from Sloan Kettering, and as we know, he's a fan of the omental lymph node flaps. And what are your thoughts on those flaps? Have you done them? And in what way do you feel that the supraclavicular flap is superior potentially?
Yeah. Excuse me. No, I have not done them. I'm aware of them. Of course, I know Mingwei and Joe very well. And that's the thing about submental that I'm sure they all work equally well, including growing lymph node transplant and others. So the reason for submental and omentum again is similar to supraclavicular to minimize donor site morbidity. Submental, it goes through there's a marginal medial nerve, so obviously there is a concern of damaging that, and also scar to me is more visible. It's not as nice as in the neck. When patients get like even thyroid surgery and things like that, you rarely see those scars. They heal very nicely. You could even wear a shirt, but this is right under the mandible. So to me, it's not as aesthetically pleasing, but I'm sure it works. And I think skin for the advantage of the submental, I think, is the skin pellet is probably a lot more reliable, and he uses it routinely, and I think they can help it. Momentum, another way of doing it. I know a lot of people have done it. Alex Friend, Roman Scrocki. Some people do it openly. Some using laparoscopy. They're not lymphatic lymph nodes per se, but they're lymphatic lakes. But the ones that I've seen, they seem to take quite a bit of it out, and you need a big space to put them. The ones that I've seen other people do, they usually have to open up the arm or the leg quite a bit. And whereas the lymph node transplant that I perform, I do pretty small incisions. I did general surgery residency, unlike a lot of plastic surgeons nowadays, but I feel comfortable going to the belly. But I don't know, when you go into abdomen, you do have other potential complications like small bowel obstruction that could occur years later. If there's bleeding, you have to open up. So things like that. So it's all pros and cons of what you feel comfortable doing. I've had a good experience with supraclavicular lymph node transplant. There was a case that was reported PRS about lymphedema arm that was caused secondarily by another surgeon, but I don't know if that was done. I don't know what kind of technique that was utilized, but so far I have not had any issues. So I'm comfortable with it, and I can do it very quickly. So that's what I do mostly.
Yeah, I think to your point, I think with all these different techniques, the surgeons who are very familiar with them have shown good results, and so I think it just shows that whatever technique you're comfortable with and you're good at, clearly they all seem to work decently well. The other question I had was about the lymphatic venous bypasses. There are obviously different ways of doing it as far as end to end, if the vein is low flow and there's not a backflow, end to side or side to end, where you plug the vein into the side of a lymphatic. Any thoughts on end to side versus side to end? I know some of our other
Yeah,
speakers have had some thoughts on that, so I wanted to pick your brain
yeah,
about that.
yeah. So I've done only two techniques, and so what I find the vein, I will do a milk test. If I see a big backflow, I don't use it. If I do milk test and see there's like a very little minimal backflow, I go end to end, especially if they're good match. If they're not a good match, then I go end to side, which is pretty easy to do. Just make a little slit, and then now the side to end, where you bring the vein and to lymphatic. I have never done that. I like to see it done because lymphatics tend to be it's very small, and I don't know technically how easy it is to do it that way. I've never done it that way. I think it'd be pretty tough because even when you do end to end, even on big lymphatics, sometimes it's hard to see the lumen. I mean, you can see it now. I see it because I do them all the time. But at the beginning, it was hard to see it. But yeah, I mean, if you got a big lymphatic that you can just puncture a hole and connect it, like I said, the advantage is that you're not disrupting the lymphatic. But you know what I do is that unlike some people, if I see a good lymphatic that goes all the way up to the axilla of the groin, I don't bypass those. I mean, it's perfectly fine. So why should I cut it? So I only bypass lymphatics that are good distally, and then it stops at some point. So I don't know. For me, the way I do it, where I choose lymphatics, where there's an advantage of doing side to end, because that lymphatic's not going to drain anyway. It's going to stop. So why not cut it? Now, if you want to bypass a lymphatic that's already going all the way across, then I guess you could do the side to end. But I don't. But then why would you bypass that? It's already draining to the lymph nodes. So that's my thought about it. But either way, I mean, I don't know. You know, I don't have all the answers. This is my thought.
Yep. Great. Well, thank you for that.
I know. JP talked about that technique, and you always ask him about share this kind of same questions. But
yeah, Ming Wei talks about that as well, and so it'd be interesting to look at that more. The other question that I had was, you obviously shown your work with the Hamamatsu, and we actually have that machine as well, and it works well. So thank you for showing us that. We had a great talk by Aki Hayashi talking about the use of ultrasound and high resolution ultrasound in identifying veins, perforators, but also lymphatics. Have you used that at all as a tool to identify these? Do you have a need for that, and what are your thoughts on it?
No, I think it's a great way to have more. The more tools you have, the better. I personally have never used it, but I'm aware of it. I mean, I know many of people have been using it. JP has used it. They published. Mario Salaiero from Italy has used it. They even have webinars on that. I think if there's another tool that can help us identify lymphatics, why not use it? I know Hamamatsu is not available everywhere for whatever reason, and maybe ultrasound is easier to get hold of. So I think we are evolving, and with all the new technologies, if we can bring more tools to our toolbox, the better. So I'm all for it. I personally have never used it. I've always have ICGM machines available where I work, so I have not found it to be necessary. But I think if you have access to ultrasound but not with the ICGM machine of one sort or another, you could definitely do that. Or maybe you can use both. Maybe there's some certain advantages to that the that ICGM machine does not have. So
any challenge with finding veins in patients who are either larger or what do you do in that case? Do you have a vein finder? Does that work in lymphedematous tissue? What are your thoughts on that?
Yeah, so I mean, some people also talked about using a vein finder to find a vein, even with using ultrasound. The more proximally you go and more deeply you go, you will have a harder time finding vein. Distally, it's not as difficult. There's a lot of veins more distally if you just look at your arm or the foot. So that's another reason why it's easier there. But no, there are occasionally, I would say it's pretty rare, but occasionally I will find a nice lymphatic, but then I cannot find the vein, and I'm really frustrated. But that doesn't happen very often. Occasionally it does happen though.
Yep.
So maybe having a vein finder could be helpful. But the thing is, if you find a vein, you got to have a lymphatic there to bypass. So they have to be at the same place.
Yeah. Great. We had a question online from one of our viewers discussing the venous drainage of the supraclavicular lymph node flap, saying that they have sometimes had difficulty with venous drainage or congestion of the flap. And I wanted to get your thoughts on, obviously, including the EJ is potentially a backup to kind of augment some of the flow. The comment on that was that our viewer mentioned that the EJ, the position seems to not be perfect for kind of supercharging the venous drainage. Do you have any thoughts on how to augment the venous drainage of the supraclavicular flap?
Yeah, so I mentioned that the EJ I don't include it. It doesn't drain lymph nodes. So I don't use an EJ, and VC sometimes can be very small. So what I do when I do, typically when I do micro, I do vein first into the artery. But when I do lymph node transplant, it's the only time that I do artery first. I do the artery first, and I'll see which veins drain. And I'll find the vein that's draining, and then I'll anastomose it, so that I know that there's some draining vein there. So yeah, EJ I don't use it, include EJ. If you're using a skin pedal, it might be a different story, but I don't use skin pedal anymore. I don't want to worry about 20-25% skin flap complication.
Got it. Excellent. Yeah. There was also a question about the Charles procedure that you had shown. I mean, these are some big cases and potentially a lot of blood loss as well. Do you have any special tips or tricks with regards to minimizing blood loss in these patients and achieving control as you go along? Any tricks on that?
Yeah. So the last case that I did, that I showed where I just peeled it off, it actually took a little bit longer than that. But up on the thigh, actually in this patient, up on the thigh above that big bump was a soft area. So I put a tourniquet there. And then actually I published this, I think it's Annals of Plastic Surgery. I slice it open from the top and I kind of try to peel it off. So in some lymphedema patients, like the last patient and the first patient I showed, that big one, the tissues were fibrotic, but still rather soft enough that I can peel it off. So I peel it off, and then I release the tourniquet and I just cauterize it. So actually very little blood loss for those two cases. The second case that I showed, where it was like rock hard, that one I had a lot of blood loss because I couldn't find the plane because the cautery and the knife just wouldn't go through the tissue. So it was very, very hard. That one took me probably like 12 hours. The other ones, like last one, took me like 2.5 hours. The first one took like 4 hours. So like the second one took me like 12 hours to go through, and that one was a lot of blood loss. But generally, otherwise, you can go, once you find a nice plane, you can peel it off right away and take it in a big chunks. You can do with relatively little blood loss. I don't think I transfused those two patients, first one and the last one. But the second one I did transfuse quite a bit.
So I guess the challenge is in the patients where you can't fit a tourniquet on, or it's so fibrotic that it's hard to find the planes.
Yeah, but if you can find a tourniquet, I would put it on, and then you got to find the right plane and just fly through.
Right. Great. We at one point hit 75 viewers from around the world, so we had a really good viewership for this. But then my next question has, I guess, more to do or is more pertinent to the U.S. Viewers. What's the status on insurance authorization and coding and so on for either lymphatic bypasses or lymph node flaps? Any kind of changes in the last couple of years?
Yeah, I get this question a lot, and I think depending on where you are, your approval might be different. So all my patients are insurance cases. I think it's very rare, except for ones who come from out of country, which I have a few of them. They all paid insurance. So what I do is when I see the patients and the patients say, I want to do the surgery, we'll submit it to insurance first. And only when they get approved, I will schedule them. Now, I would say lymph node transplant, which is called as a free flap, is very rare you will get denied. Lymphovenous bypass can be denied. So in those cases, I have developed a very modest fee that they can pay out of pocket that most people can afford, because I know that lymphedema patients are not necessarily wealthy people or have a lot of means. They're not looking to do this like aesthetic surgery where they save the money for. So we can do that as a add-on to pay for. Same with lympha. So make it possible for patients to do them. And for the most part, I've had, I would say, about 75% have been approved. Now, Medicare, it's approved. Medicaid, they don't pay a lot. Okay, they don't pay a lot, but they will cover it. Medicaid covers it. So if you don't mind doing it for low fee, you know, you can do them. But you're not gonna get a lot of money from them, but they will cover it. So, right. Yeah, for me, I've had a reasonably good success with insurance companies, and sometimes I do have to talk to them. To medical doctors, and I send them my publication stuff like, and they will oftentimes will go ahead and approve it. But there is a small percentage where it does not get approved.
And are you using, what we do is we use the vessel repair code for the LVAs. Is that also what you're using?
You know, so we went back and forth, different codes, starting from MD Anderson, and because I use the code that our coders feel comfortable using. Sometimes they said, oh, I don't know, that doesn't seem right. So for the LVA, I use the it's an unlisted code now, which is terrible because that's what gets kicked off. So I use a vessel code, a vessel repair code, and then 38999, which is an unlisted lymphatic code.
Got it.
And then 3899 is one that gets kicked out quite a bit. But then I will tell the patient, if you want, you can pay, you know, whatever, and then usually they will say, okay, I'll pay.
Yeah. Great. I know that Dr. Greg Buncke is on the call. Greg, I wanted to call on you for a comment or a question. Are you there?
Yeah. Hi, David. Thank you so much. That was a really great talk, and I'm always impressed by all of the stuff that you've done. All based in the amazing thing, and this is the first time I've heard about how you came into starting to do lymphatic surgery, was this trip to Japan with Koshima, which is really interesting because that's the sort of thing that I think a lot of young people need to know, that it's important to kind of go out and get inspired and then get new knowledge and recognize how that can help patients, especially in your situation where you knew you had a bunch of patients that probably needed this, and then you struggled through the hard times of trying to develop that whole thing. Could you talk a little bit about that? How you kept going?
Yeah, I think these traveling fellowships that many societies have, like ASM, they have the Godina, and ACS have this Japan traveling fellowship and things like that. And I think early on, when you go and visit these places, it's a great opportunity to not just to meet people, interact, which is great because you can find lifetime friends, but see the new techniques and new approaches that you are not even aware of, or maybe you are doing something, but you find that there's somebody doing it differently. It kind of opens your eyes to something, I think, that's very, very valuable. And I would recommend all the young people to go and visit and see as much as possible with open mind, and you have to be open-minded about it. You cannot just say, oh, that doesn't work because I've never been taught that way. Well, you know what? You just don't know. You just have to have open mind, and it is possible that things that seems kind of crazy actually are not so crazy after all. And I don't know, nowadays with all these webinars and all these online things, maybe it's even easier for you to learn about what's going on throughout the world without actually even have to travel there. So perhaps one of the good things about this all this COVID-19 and travel restriction is that maybe that now we have more opportunity to interact. And I think it's always good to question what we have been taught, what we have always believed to be true. You know, all the things I know. Buncke has a talk about how to, you have this little slide when you talk about all those things that people have taken for granted for all these years and proven not to be true. So I think we have to always question and be open-minded. So yeah, traveling is good. Or if you can't travel, just visit people online, virtually.
Yeah, I think that's a fantastic point. I think, and that was one of the biggest learnings for me last year, was just how much there is out there and how much great work is being done by our colleagues overseas. And I think if you keep an open mind, you will certainly learn a lot of things that you didn't even know was out there. So with that, Dr. Chang, thank you so much for being with us. It's been a pleasure hosting you, and it's always great to see a member of the Buncke family who has accomplished so much from early in his career with the Godina Fellowship all the way through the presidency of ASRM, and actually I forgot to mention the presidency of WSRM. So I'll make sure I include that in the slide for the next introduction when you do your vascularized bone talk.
Okay, thank you so
Yeah,
much.
but thank you so much for being with us, and please say hello to all of our friends at the University of Chicago.
Thank you. Thank you, everyone.
Great.
Have a nice
Thank
day.
you.
Bye-bye.
Bye.